only 150 or 90 people were there out of a big number of the class. Anyways, those who are not interested, I'm happy for them. Okay, now did you find time to check on notes? What did you find new? What type of lecture was that? Don't see now. If you have seen it, just tell me. Because I know you can your fingers are moving and you are looking at it now. So what type of lecture was this thing? No. The one who started, I like to ask her, guys, listen. I have learned one thing in my life. If I have done something, I will say it, I have done it. And if I have not done it, I should have the courage to say it, I haven't done it. No one kills me. If you haven't seen in that lecture, it's okay. Say it. I saw it, but I didn't open it. So learn to say the truth because practice of medicine is all about the truth. You have a patient, something went wrong. No, I haven't done anything. You think others are fools? They can figure it out where you made a mistake. And you try to hide one thing, you'll be facing 100 more things. So that is really important. Anyways, the person is around, so I'm sure he'll take
Yeah, yeah, yeah. I'll do everything. You just relax.
Okay, guys, good morning. Sorry for a little delay, but technology has to be failed somewhere, somehow, like always. So now, this hand, whatsoever we are learning from last 3.5 weeks, the whole activity was connected to today's lecture. And our upper limb is made for controlling the hand. The most advanced, most beautiful machine of this world, which has been made ever. I doubt it. Such a best machine can someone will be able to make yet. So it's such a complex system of so many things where we cannot imagine. We have made robotic hands and so many things, but if you compare that robotic hand with your own hand, the performance, the quality, the transition, everything is entirely different. There is no match. And this hand, what is the function of this hand? Why we have this hand? And before that, why we need an upper limb? What is this upper limb is doing for me and you? So, lower limb is for locomotion, and upper limb is for prehension. I can perform so many fine and crude type of activities by the help of this hand. And this hand is being controlled by all what we have learned so far from the lecture 1 to this lecture number 7 or 8. On your schedule, it is number 15. So all that is connected to that kind of activity. So this hand, it's something worth mentioning that I can start with these words that this hand is so important for me and you. And if you understand this part,
ये सब हो जाए तो आपने मुझे बताना है
so we have to be good with this part and we should be able to understand. I know what I'm doing today with you, it's a complex topic. And this topic, it requires good understanding. Time is less. Don't get stressed. I said yesterday, we will try to make a justice to give you the items in your upcoming exam should be matching with your with the normal standardized prep. We are not challenging you here. And remember, don't take this message home. Whatsoever you have covered in midterm, you are done with that. No. That is just the beginning of the story. The same concepts will be assessed in the final. So, more will be coming, more details will be addressed in the finals. So, today, whatsoever we are learning, because this hand lecture has a lot of content, but you have to stick to the broad picture. Don't go in too many details. Details, we have time, we'll go over. Relax and continue your learning process. These middle exams are designed to help you, to show you your progress. Every week, TPL is there. TPL is not to stress you, TPL is to help you to see how you are progressing. Fine, today I don't do good. It's okay. It's not affecting me in a big way, but I should look for my tomorrow. But if I don't look for my tomorrow, then I feel sorry. And you are requested, and we like all of you should be connected. I know it's a difficult time, and there is no thing has developed yet which can replace this face to face. We are looking for, we are trying for. So, with this note, I like to start with that this learning, what we are doing right now, it will be helpful not for tomorrow, but for your lifelong learning. No matter which field of medicine you'll choose, the hand will remain a continuous point of concern, and you will be facing people with the problem of the hand in different ways. It's not necessary that fracture is the problem of a hand. There are so many issues, and in your life you'll be watching, you'll be looking a lot. So now, without wasting words, let me start. So when we talk about the anatomy of the hand, the lines which I have used these, so these are the slides that hand is what is an ultimate operative tool and all that, so you can read these slides. But primarily, hand is there for two principal activities. And what are these? What are these principal grips which we should be understanding, grasping? One is a power grip. A power grip. If I have to unscrew, if I have to open something which is tight enough, I need to have power. So this is one function of my hand. The other function is precision, precise grip. What is precise? You are asked to put a thread in the head of the needle, which is so tiny. You are asked to do some craft work. You are asked to suture. These all are kind of crafts. Painting, drawings, playing organs, all those things are specific, and these are the precise movement. They require your precision, how good you are. So hand is primarily doing what? It gives me a power grip, and it gives me a precision of my grip. I hope everybody understand what do I mean by saying precise, to the point, ultimate. So for the power group, we have extrinsic muscles. And these extrinsic muscles, we learned, they were on the flexor side as well as on the extensor side. Flexor side is more stronger because look at your hand. You are making a grip. What are you using more? Flexors. Extensors are only used for what? Just to open it out. Make sense? So this thing should be very clear. So this is for my power grip. And for precision, I have intrinsic muscles. Guys, don't mix the concept of intrinsic and extrinsic with the concept of superficial and deep. They are two different entities. Intrinsic means it's localized to a surrounding. Intrinsic means if I'm talking in this room, it will stay in this room if we are not connected with the rest of the world. That is intrinsic talk. But now we are holding an intrinsic cohort of the students and the extrinsic cohort of the students. So there is no superficial and deep. So you, those of you who are sitting here, you are the intrinsic students. You are localized to this room. And those who are looking us, those who are watching, they are extrinsic. So there is no superficial and deep, and don't try to mix these two concepts. Are we clear? So with this note, let me proceed with, and then we have a variety of combination for performing various activity. We need power, we need precision, and we will learn that, and I will show it to you. So now, power and precision, power grip, its definition, precision grip, its definition, you can read it. I don't want to read the lines. I don't like it. So now, flexor synovial sheath. You remember the lecture where I was talking about flexor compartment of the forearm. I told you about this slide. We will do in detail. Wait, right now, let me go fast. So today I like to do in detail. So flexor synovial sheath is a kind of, the word synovial, you should be connected to the synovial membrane. It's a sleeve-like thing which encloses my long flexor tendons. And their job is to what? Lubricate those tendons, facilitate their movement. So they should move without any friction, without any problem. So we can perform what we have to perform. Tell me, when you are grasping, when you are making a fist, when you are holding something, can you hear a sound? So many tendons are moving, but we don't hear something. So we have a lube inside. And who provides this lube? Is the synovial fluid. From where I'm getting it? Through the synovial membrane. So let's put this concept, and I'm showing you what at the moment you're looking at a metacarpal and three phalanges. So it could be my digit 2, 3, 4, or 5. If it was digit number 1, it could have been only 2 phalanges. So now let's label them. This is the metacarpal bone. This is the proximal phalanx, middle phalanx, and distal phalanx. So for my convenience, I label them as P1, P2, P3. P goes for phalanx, 1 for first, 2 for second, 3 for third. 1 is proximal, 3 is distal. Proximal, anything towards me. Distal, anything away from me. Are we good? So now, let's look at the palmar side, because we are talking about flexor synovial sheath, and my flexors are present on the palmar aspect. They are not on the dorsum of the hand. This is the dorsum of the hand. This is the extensor compartment. But this is the flexor compartment. This is all here is the palmar side of my hand. So now we have a long extensor tendon. We know about this tendon and we label it as extensor digitorum. The job of this to extend my digits. What are the joints which are coming on the way? You can see yourself. The joint between middle and distal phalanx, proximal and middle phalanx, and metacarpal and proximal phalanx. So these joints are coming on the way when this tendon is going from the extensor side. And the job of this is to open my fist. Remember, when we are opening a fist, we need flexors as well as extensors. You may ask me a question, what the hell? From where you bring this? I'm flexing my digits. And you are saying we need also extensors because we need to have a stabilized fist. Can you see that? You make a fist like that. And there are certain people, their fist is something like that. What is the difference? There is some deformity. Extensors cannot do well. So the fist is unorganized. I have more flexion. I have more prime mover activity, but no one is antagonizing that. No one is agonist. So no one is opposing that. If you have an unopposed movement, this movement will be too rigid. It will not be coming in the proper shape. So we need both. Those who are in favor and those who are against that. That concept has to be very, very clear. Okay, let's go further. So this is, we all know, this is the tendon of extensor digitorum muscle. And now, what is this gray thing? This we call it as extensor hood because it's connected to my extensor tendon. It's something like, now the season is coming. Shortly, you'll be seen wearing your hoodies. So this is a hoodie of my extensors. So this basically a sheath, a fibrous sheath, which provides more attachment, which stabilizes. You can see that if it's only attached at the tip of my digit, there are fair enough chances that this tendon can move from side to side. But on top of that, there is a membranous structure, and that provides a uniform attachment of this tendon. So it is being stabilized. So this extensor digitorum tendon has been provided with this extensor hood, and that is helping in the stability of, and this is on the dorsal side of my hand, so we call it dorsal digital expansion or extensor hood. The job of this to stabilize this tendon during the movements of the extensions which has been brought at my digits. Okay, now you're looking at a long tendon which goes all the way to be attached on the base of my distal phalanx. This muscle should be flexor digitorum profundus. Its distal attachment says that. Even if I don't look at the other part of this muscle, I can say very politely, if it's going to my digits, not to the thumb, I will say it's on the palmar side. Just looking at its distal attachment, I know it that I'm looking at flexor digitorum profundus, because that's the normal site of attachment of my flexor digitorum profundus. Now, overriding that, I have a muscle which splits and then attach to the base of my middle phalanx. And it splits for what? To give way to the tendon of flexor digitorum profundus. So the job of that is to allow the free passage of my flexor digitorum profundus tendon. Are we good? Okay. So now, as we are talking about this purple sleeve which is covering all of that. And that purple sleeve, we name it as flexor synovial sheath. The job of this sheath is to lubricate, to facilitate the free movement of these tendons. And they are moving, they are going, they are gliding, they are sliding without any trouble. Are we good? Can you help me closing that light? Yes. Thank you for your. So, you are looking at flexor synovial sheath. Thank you very much. And this flexor synovial sheath and these tendons, they need to be stabilized. For their stability, we have these flexor digital sheets. They are not like my extensor hood. They are in patches. And their job is what? They are stapling, they are holding flexor synovial sheet along with these tendons to be attached to the bone. Which bones? To my phalanges and to my metacarpals. Are we good with that? So these bands, these flexor bands, flexor digital sheets, their job is to stabilize this common flexor apparatus. I will call it an apparatus because it has two tendons and itself is a sheet, and it is basically facilitating, it's providing that will helpful while these tendons are rubbing against each other. So they are minimizing the effect of rubbing. So they are minimizing, they are facilitating the free movement. And then they are named, they have an annular portion, and then they have a cruciform portion, and together it's called as what? The flexor digital sheet. So they have different type of formats. I hope we are good with this. Now, this is a detailing. What I'm saying here, inflammation. If let's say, I'm visiting a garden, I like a flower, and as a bad habit, I will try to unpluck this flower. We should not be doing that. So, flower is protected by thorns, and one of the thorn hit my pulp, my digit. So, I don't know how much poisonous was that. There is some nidus, there is something which has entered into my flexor synovial sheath. If this inflammation persists, if this inflammation progress, I'll develop synovitis, inflammation of my flexor sheath. If it involves the tendon, I will use the term tendinitis. And then a combination of what? We can have tenosynovitis, and then we can have tendosynovitis. So tendosynovitis is what? Inflammation of the tendon and the sheath, and then we have these. The term you should be clear about what is tenosynovitis and what is tendosynovitis. The names are itself giving you a clue, and this is how this infection, guys. This infection can reach to middle of your forearm. How? We'll be looking at shortly. But there are fair enough chances. So be aware of if your finger got pricked and you can feel a serious pain in your forearm and you start thinking of, oh, I'm developing something like a compartment syndrome. Why it's so painful? Because there are connections and we need to learn those things. But I told you slowly. So now let's look at now dorsal digital expansion. So we were looking at flexor digital expansion, and now we'll be looking at dorsal digital expansion. For that, I need to get this thing from the other view, from the dorsal view. And then we all know about these bones. I need not to say again. And these are the joints: metacarpophalangeal joint, MP joint, and then PIP, proximal interphalangeal joint, and then what it should be, DIP, distal interphalangeal joint. This is my tendon of extensor digitorum, and it is pulling backwards. So as a result, I can have this extension at my digits, at my wrist joint. So this is what type of thing? This is a power. Let me minimize this thing. Probably it is obstructing your view. So this is power extension of the digit. Are we good? I need to bring him down. Yes. Why you're angry with me? So now you're looking at dorsal digital expansion, and what is this doing? It's keeping a sturdy attachment throughout the length of my whole digit. So it's stabilizing the tendon of extensor digitorum, and once I'm contracting my extensor group of muscles, in particular extensor digitorum, as a result of that, my fist, which was made like that, it will go in an extended format, and this will be lifted because it's attached. It's attached where? It's attached at this place. So I get this performance when I'm doing this. Are we good? And there are my flexors, and they are opposing this movement. So you're looking at superficialis and profundus flexor digitorum, superficialis and profundus. And once they are contracting, I'm making a fist. When my extensors are acting, my wrist is been opening. So there is an element of, so they are opposing each other. So this opposition brings me a stable movement. If any of these movements is not there, if any of this factor is not there, I have unorganized, I have unopposed movement, and this unopposed movement will not give me an organized fist. I have a deformed fist. That we need to understand. Now, what are these? These are special type of muscles. So these are precision, intrinsic muscles. So you are seeing before extrinsic muscles. So now intrinsic muscles. What are they doing? Coming, emerging within the hand and terminating within the hand. It's not necessary they go to a bone. This one is going to a tendon of extensor digitorum, coming from a bone, going into dorsal digital expansion, and the tendon of extensor digitorum. This is what, and this is for precision, and this is an intrinsic muscle. Their job is precise movements. Are we good? So we have to understand why we need intrinsics and why we need extrinsics. So this is one of them, and that is, it has a name. What we call it? Intraosseous. This is a specific type of group of muscles, and we have so many intraossei, both on the palmar side and on the dorsal side, and they have different pattern of their attachments. We are not supposed to go in their details, but we should be knowing those who are visible to me on the palmar side of my hand, they are called palmar intraossei, and those who are present on the dorsal side of my hand, they are called dorsal intraossei. Then we have another group of muscles, and they are called as the lumbricals. You heard this term, the lumbrical. Look at them. This muscle is coming from a tendon and is going to a tendon. It has to do nothing with any bone. From a tendon to a tendon, to a digital expansion. Are we good? So now, this is an example of lumbrical. So, the intrinsic, if somebody asks you, who are the intrinsic muscles of your hand? Your answer should be, we have thin R eminence muscles. We have hyperthin R eminence muscles. We have intraossei, and we have lumbricals. So these broad 4 categories of the muscles are called as the intrinsic muscles of the hand, and they are responsible for giving me the precise movements. So now look at the axis of the movement. When I'm bringing these, so this is the axis. It goes in this action, and then we'll be having movement occurring at different joints, and these different muscles are playing their role in bringing all these activities. So flexion, for flexion at this metacarpophalangeal joint, we have to perform in a transverse axis. And now you can see that as a result, for extension, we are pulling these things, and we can achieve a distension. Now look at it. Tata hand position, guys. This slide is, I think it's beyond your level. I'm not spending time on that. I will explain it later, but not today. Just ignore this slide. Let's go fast on that, as fast as we can. This is also the same. This is too complicated. Not for you at this level. Not recommended. But for final, yes. Now, coming to this image. What are you looking at? It's someone's hand. And what this person is doing. These are, it's written on this slide, movements of the thumb. So we can move our thumb in different direction. What for? And what are these called? Every movement has a name. You are learning from the beginning of your journey, flexion, extension, abduction, adduction. We don't use here lateral medial rotations, we use opposition when they are opposing each other. So now, let's look at these movements. Let's label it. So guys, this is called flexion. Please be reminded, you should be very clear about the axis. If you ignore the axis, you will be mixing up between so many movements. So this is, my hand is like that, and I'm bringing my thumb like this. This I call flexion. Where? At my first digit, pollicis. So that is my flexion. And if I'm opening it backwards, so this is a neutral position. This is extension, this is flexion. So movement is occurring in which joint? So this is flexion. And then this is bringing it back is extension. Are we good? Guys, it's not an easy thing. You have to spend time on this. And now, my hand goes like that. Before I was showing you like this, now I'm showing you like that. So when I'm showing you like that, now just look at it. It's added. It's like my neutral position. It's adducted. And if I bring it backwards, it's abducted. And you can mix between flexion and abduction. This is the adduction. and that one is the abduction. And we have to understand, you are requested to spend time in understanding of these movements. That's called abduction. Now, the last thing, you are counting on your digits. Pinky and the first digit, digit 5 and digit 1. This is called opposition. This is the opposition movement. And for this opposition movement, we have specific muscles. They are designated for these. And they are called opponents, digiti minimi and opponents pollicis. Opponents pollicis for my thumb and opponents digiti minimi for my pinky. So this is how we can achieve the different movements which are occurring at my thumb, and you are expected to be good with them for your finals. Okay, so now let's proceed further. So let's revisit the bones of the hand, palmar view. Palmar view, when you're looking at, this is the palmar view, this is the dorsal view. So we know this bone, no rocket science. And we know this now, scaphoid. I put a sign here next to it. Most commonly fractured carpal bone of human body. If somebody falls and outstretch hand, foosh, F-O-O-S-H, there are fair enough chances of fracture of scaphoid. It doesn't mean that other carpals cannot fracture, but I'm using the term most commonly fractured carpal bone in human body is scaphoid. Then trapezium, so these are the names for them. Now this one, lunate, most commonly displaced, dislocated, dislocation where it occurs. If a dislocation is occurring in my carpals, the most commonly dislocated bone will be the lunated. These 2 points should be very clear. Guys, anything emerging in red, you should be connected to that. They are important. Doesn't mean others are not important, but these things, these factors, never forget. So these are the other names for my carpal bones. Are we good? So they are carpals. The joint we know, we talked about it yesterday night. So those 2 lectures which I have posted yesterday night, they are asynchronous lectures. One is talking about, and that is what was my question in the first place. I know you have not seen it. I was damn tired when I was recording those. One is dealing with the wrist joint and other one is dealing with the Colles and scaphoid fracture. If you want to have reconnection, go back to your Moodle, open that folder, and you'll find these lectures with their presented material, and you are expected to go through this material because it is connected, and you have to be good with those things as well. So now, these are my metacarpals, proximal, distal, and middle phalanges. Are we good? We talk about these things. Now the joints, carpometacarpal, metacarpophalangeal, proximal and distal interphalangeal joints. Okay, let's go further. So the life is getting to the reality. We start from an image. Now we are transforming how a patient will come to you. Patient will not come to you with a drawing of his own hand. Doctor, look my hand drawing, how beautiful it is. No. Patient will come with a problem and you will be requesting an X-ray. When an X-ray comes to you, you should be as good as you were with the image, with that drawing. So let's label it here. This labeling, it's your practice. Spend time on these things. We call them carpals, metacarpals. I use something new here. Sesamoid bone. So we have sesamoid here. You see that? So this is an example of sesamoid bone. We know that sesamoid patella is an example, but you can also find a sesamoid here. It may be there, may not be there. but you are expected to be good with this image, with this X-ray. And at least we are not expecting you to come with a treatment plan, but you'll be asked and engaged like in your TPL, you saw that. You are asked anatomical basis, anatomical mechanisms has to be there, structural mechanisms. You should be good at those. We are not talking about management plans. So now that image has transformed into this drawing and the same concept, and you're looking same at the palmar side. We're not looking at the dorsal side. Please stay connected with me. So now let's label the things. Be good with that. Pre-axial and post-axial. My first slide for MSK was this, where I was talking about pre-axial and post-axial. My first digit will always be lateral if I'm standing in an anatomical position, and my fifth digit, pinky, will be in medial position. Are we good? Now, let's make it more. So this is my pollex, pollicis, digit 1. Now this is the axis. On the basis of this central yellow line, I will perform all the activities, which passes through my third digit. All the movements, so many actions will be with reference to this line, and that will be my median plane, the reference plane. These are my carpals. We are good with that. Nothing new. We are good with this. Every phalanx has a base and a head, base and a head. But thumb has only two phalanges. It don't have three. So my first digit has only two phalanx. You should not forget that. Now, we know about this joint, radiocarpal or the wrist joint, midcarpal, carpometacarpal. Any rocket science so far? Anything new? Anything which bothers you here? Judy, can you check any question?
Someone's asking how we can differentiate between the sesamoid bone and the dislocation of the fracture bone.
It's very obvious. Sesamoid bone is something which is in isolation. It's not connected with your skeleton. It's separate. And when we're looking at a fracture, we should look at the cortical core of the bone. I'm sure histology people must have talked about the cortex part of a bone.
What's the difference between the synovial sheath and the conjoint?
Synovial sheath is just a sleeve which covers my flexor tendons. And extensor hood is a cover, a wrap, which encircle. It's not a, you have seen it, it's not a complete sleeve. So it is just an extension from my extensor digitorum tendon, and that is connecting throughout the length of my different phalanges and metacarpals.
What's the function of the sesamoid bone?
Function of sesamoid bone, gentlemen or whosoever, go back, read the classification of bones, you'll find the answer there. You need to connect backwards. What else?
Someone's asking where does the axis arise from?
Where is this axis arise from? This axis we made for our understanding. Like if you look at, if you move your digits, you are moving towards the center. So this is for our better understanding. Do you see any axis in your hand? Or any one of your, any person nearby to you having this dotted line in his hand or her hand? No. So it is just for our understanding. What else?
How do you differentiate between abduction and extension?
How you differentiate between abduction and, basically this person is trying to ask abduction and flexion. That I use a term flex, the axis. If you are good with the axis, then you can. And everything needs practice. You heard this term today, few minutes back, and you cannot be master in that. You have to sit down. Trust me, when I'll be talking about the movement of the thumb, I myself sit down, spend good hours to really look back and reconnect my thinking process with the realities. So it's not something just you hear it and you remember it. Never. You'll do it, you'll learn it. You'll hear it, you'll forget it. You'll see it, you'll forget it. But you'll do it, you know it. Anything else, Judy?
Is the extensor hood the same as the extensor expansion?
Yeah. Extensor hood and extensor expansion are the same thing. Any other question?
Someone is saying that trajectory bone is not clear on X-ray.
You need to relook because this is a real X-ray. It's not a picture. So you can match a picture with an X-ray. You have to learn it. It will never speak out for you. This is how this X-ray has been taken.
What's the difference between tenosynovitis and tendinosynovitis?
One is the involvement, and it has been explained in that red box very clearly what is tenosynovitis and what is tendinosynovitis. When you'll find this recording and this lecture resource material, you will be able to understand that. Teno and tendo, they are very clear. What else?
How do you see a lunate dislocation?
Okay, I will bring that lunate dislocation in your exam, then you will see it. Don't worry, be rest assured. Remind me, guys, before final, I'll hunt for a lunate dislocation and I'll ask this person. Only for him or her, not for everybody. I think we are good. Any other thing? Perfect. Thank you, Judy, for your interim input. So now, I hope we are good with this much. Let's, yes? Thumb with your pinky. Thumb with your pinky, thumb with your other digits. You're counting. You remember in your school time, your teacher was asking and you're quickly counting on your digits. I don't know you're doing it, but I was doing it in my early math classes. Oh, I'm quickly hiding my hand and counting, and because when it is that mental math type of sessions, and there you have to be counting, adding, subtracting, and all that. Anyways, so guys, I don't see any problem with this slide so far. So let's take everything out. It's plain again. Now let's make it more complicated. So let's bring here the ligaments. Again, we are looking at palmar surface of a hand. So now, the ligaments, you can see that. The ligaments who are connecting, these are the collateral ligaments. You remember? For the elbow joint, you have these collaterals. For the wrist joint, you have these collaterals. For the mid-carpal joint, you have these collaterals. Now bringing down, still you have the same collaterals. And they are on both the sides. And then what are these? These are called palmar ligaments. These are plates. And then there are connections between them, and these connections are called deep transverse metacarpal ligaments. So they are connecting. They runs transversely. You remember somebody transverse humeral ligament, which was plastering the long tendon of my biceps in the bicipital groove. And that is never a part of my glenohumeral joint. So this is deep transverse metacarpal ligament. Okay, going further, what is this? I'm sure you'll be familiar with this person. This blue thing. Who's that? Flexor digitorum superficialis. Excellent. I can assure you, if you can recognize this, nobody can stop you from scoring good in your midterm MSK exam. Be rest assured. That's my promise to you. We call it flexor digitorum superficialis. Tendon. And who is this person? Excellent, mashallah. You guys are smart. I'm sitting down. Come and teach me. You guys knows everything. Great. I love you guys. Only you need to little revisit. Rest, you're fine. You're. You know what I see? You're ready. You're ready to go. Only you need a little bit push. That's what I'm struggling at. I'm trying to give you a push, but you know it. So this is the flexor digitorum profundus tendon, which passes through superficialis tendon. And how you say it? Because you have an evidence, it is connected distally to the base of my distal phalanx. Now who's that? Think. Flexor retinaculum. I may take your word, I may not take your word. So this is palmar carpo metacarpal ligament. This is a different thing. And who's that? Don't get confused if your answer goes wrong. I make a mistake, I will learn from it. I should learn from it. And then next time, I should not make that mistake. I should not repeat it. And we call it palmar metacarpal ligament. Guys, if you don't know about these ligaments, it's okay. Don't stress out for them. There are so many details. And when we develop these resources, we develop for all kind of people, because these sessions, these lectures has been used in multiple layers, in multiple level of understanding of med students in different parts of their life. So once these resources has been developed, it was considered to put everything here. But for you, if you don't know about this part and this part, it's okay. So now let's go deep. I have removed everything again. Now, who's that? Somebody who's coming from my first digit and second digit. Which part of my first and second digit? Now you're going to tell me. Metacarpal. Excellent. So you guys knows your stuff. And from the metacarpal, this journey ends where? To the radial side of my second digit of what? Proximal phalanx. Excellent. So, and there is someone else. Look at it. They all are following radial side. Now, from this side, they are following ulnar side. So these are on the palmar surface. I may call them, allow me to call them palmar introccei. So these are palmar introccei. I use a word DAB in capital, DAB. So these introccei, and right now, what is happening? Are they palmar? No. You are looking from the dorsum of the hand. So you are looking from the dorsum of the hand. So these are not the palmar introccei, these are the dorsal introccei. And dorsal introccei, a word goes with them, DAB. That explains everything. Dorsal, DAB. So dorsal introccei for AB. What is AB? Abduction. So what dorsal introccei do for me? They do abduction. And what is abduction? So I can stretch my fingers outwards. That is abduction. And who's helping me to, if I want to check, if you want to check your dorsal introccei are working or not, just open your digits. Open your fingers like that. Can you see me, guys? No? But if you open your Zoom, just tell me, can you see my hand movement? Tell me yes or no. No? Why camera is off? Okay, I will turn the light on later. But remind me, I have to show you that. So my fingers are going apart from the middle finger. So this is the action of my dorsal introccei. Going further, now this is the palmar side. Another color has been used. These are also four. I cannot show you the fourth one because of overlapping concept. And these are palmar introccei. And at the end of this palmar introccei, the word is written pad. First word was dab, and the second word is pad. Now, do you mind opening that light again? Because I think you should be shown what I was trying to tell. Okay, so now this my hand. Can you see my hand? This is adducted. So this is the action of palmar intraossei adduct. So this is the action of palmar intraossei, and this is dorsal intraossei. If I want to check the dorsal intraossei are doing well or not, so what I need to do, I ask the patient, I'll put my fingers here, and I'll ask my patient, open your fingers. And I can see how much power strength. So that I'm testing the action of what? Abduction. And who's bringing abduction to me? Dorsal intraossei. And if someone's hand is like that, and now I ask him, close your fingers, close your digits. So now I can apply my finger here and I'm opposed his movement. So that is I'm preventing him to bring adduction, and that's where I'm testing the palmar intraossei. And when I'm doing this adduction, I'm using dorsal intraossei, and when I'm abducting, I'm using the dorsal. So we need to be good with this dab, dorsal intraossei for abduction, palmar intraossei for adduction. This concept has to be, it's not a rocket science. You can just look in your own digits and you can do it. Abduction, adduction. Where? In my digits. Are we good? So this concept has to be very clear. And if you see on my slide, it's written 4 and 4. And then you know, I know every year I receive this question, doctor, in your image, you are showing only 3 and you are saying 4. Fourth one, because this image is not a 3D image. This is 1D. Okay. So now, let's proceed. Huh? Fourth one, obviously, on the other side, but I cannot show you at the moment. Do you mind? Yeah. No. They are just in between. You have to read them and then you will understand them better. So, are we clear now? So, we have seen palmar and dorsal intraossei. Where are you, my dear? Yes. Hmm? No, don't bring now adductor policies or anything else. This is all about different level of movement. So these are they are those muscles what you're talking, they are bringing the movements of the thumb and all that. So this is between my digits, internal actions, what I'm talking here. Yeah, perfect. So now who's this coming up? Which side? Can you see somebody's creeping in? Radial artery. Where I can see the radial artery? Can you see here? The part of my screen which is highlighted. So that's my radial artery. So it is entering. And what location it is? Do you remember exactly? This was anatomical snuff box. The location corresponds to my anatomical snuff box. Anatomical snuff box is at the base of my first digit. And look at it. It runs in the, and we learned that the radial artery is the only content of my what? Anatomical snuff box. It go through there and it pierces a muscle called intraossei. You can see that it is piercing a dorsal intraossei, and by doing that, it is reaching to the palmar aspect of my hand. Before it was on the dorsum, it was laterally. It pierces it. It enters, it runs, it pierces it, and then it reaches to the palmar aspect of my palm of my hand, and then it's giving branches. So it pierces what? First, dorsal intraossei muscle. You can see it is been piercing that. Going further, you can see it gives a branch that is going to my first digit. First digit It's so special. Guys, my and your hand, if we remove this first digit, thumb, we cannot do much other than slapping people. That's the only function we are left with. No grip, nothing. So the artery of my first digit has a very special name. Principus pollicis artery. I'm sorry for the difficult name, but this is how it is. Some books you might find arteria principus pollicis, the principal artery of my pollicis, the principal artery of my first digit. So the prime job of my radial artery in the hand is to give nutrition to my first digit, pollicis, thumb. Are we good? Then what happens? It is supplying to my second digit on the radial side, right up till the distal phalanx. And that has radialis indicis artery, because this is my index finger, but it only supplies. So these are the two supplies which we derive from the radial artery in the hand, primarily. Now, it meets with its counterpart. It goes transversely. It makes a deep arch. And this deep arch is with what? On the ulnar side, we have ulnar artery. And they are joining, they are making the deep arch. It is located deep in my palm, just after this joint, and we have this deep palmar arch. Deep palmar arch is primarily made by radial artery. After it gives these branches, two branches, one which supplies my first digit, and second, this branch which supplies half of my second digit. So we have arteria principis pollicis and arteria radialis and indicis. So these are the two branches which are coming from my radial artery. And then it makes a transversely going arch, and we call it deep arch because it's located deep in my hand. And it articulates it anastomosis with my ulnar artery. So the main blood is being poured from the radial artery, but it is connected with the ulnar artery. Are we good so far? Okay. So now deep palmar arch, you have seen it, and it is from the radial. So remember, I have wrote in the bracket, the main source is radial. Going further, this is the ulnar artery, we know it. Now what is happening? My deep arch gives small branches, metacarpal arteries. Can you see that? My deep arch gives these small branches which are only localized to the metacarpal area. Now I'm adding up another muscle. This muscle is going to my pollicis, my first digit, to my thumb. It's triangular in shape. We don't count it as a thenar eminence muscle or hypothenar eminence muscle because it's in the center. Its name is for thenars, but it's not a thenar because its nerve supply is mostly from the nerve of the hypothenars. And this muscle is adductor pollicis muscle, and it emerged by two heads. One you can see it's coming from the carpal bones, and the other head is being coming from the third metacarpal bone. They emerge and they are connected to my first digit, to my thumb, to my pollicis. And the job of this muscle is to adduct my thumb. And all we need to practice how we can bring adduction at the thumb. This is my adductor pollicis muscle, and it is being basically it's been transverse and oblique. It has two heads, a transverse head and an oblique head. Are we good? Going further. Now what happens? You can see that this deep arch, the radial artery, when it enters my palm, how? After piercing first dorsal interossei muscle. There it gives a branch with the name of arteria principis pollicis, arteria indicis. Then it goes, it makes an arch. And who's on the other end of this arch is the ulnar artery. While it's going towards the ulnar artery, it also pierces the transverse head of my adductor pollicis muscle. So this artery is going through two muscles. One is first dorsal interossei, second is transverse head of my adductor pollicis muscle. We need to be good with these two words. Now, with the ulnar artery, you can see someone yellow is coming up. It should be what? Ulnar nerve. And this is the deep part of my ulnar nerve. It's going forward. It follows the deep palmar arch. It goes parallel to that. And now I'm using a different color. Two shades of yellow at the beginning. Where? Can you see it in this image? Yes. There you can see. So this one will be my ulnar nerve with its superficial branch. And what this superficial branch is doing here. But before this deep branch, you can see that it's going and supplying what? On the thenar side, it's supplying my adductor pollicis muscle, both heads of it, and then it's contributing to my interossei muscle. All the interossei are innervated by ulnar nerve. Lumbricals, half and half. Then you can see my deep branch, muscular branch of my ulnar nerve is supplying individually interossei on both the sides, both palmar and dorsal, on its way when it is running transversely. Are we clear? Now, do we know this blue thing which has just emerged? Is it a vein? No. What it is? Tendon of? Guys, can you speak loud? Flexor digitorum superficialis. I told you when you come to this session today, come with some energy. And who's this? The same tendon. So I'm putting all the tendons of flexor digitorum superficialis. And then, who's this? Which one? Let me remove it. See it again for the first digit. Somebody is approaching to my first digit. On the palmar side, who it should be? Flexor pollicis longus. Excellent. One of the deep muscle of my flexor compartment of the forearm. Flexor pollicis longus tendon. And then who's this? For the second digit. Flexor digitorum profundus. First, second, third, and fourth. Are we good? Now, what is that? Now you're looking at someone else who's traveling from a tendon to a tendon. Tendon of profundus to the tendon of extensor digitorum. And yes, thank you very much. I heard a whisper, and that whisper is saying you're looking at now the lumbricals. So these are the lumbricals from a tendon to a tendon. Are we good? Let me minimize that because it will be obstructing my image. So these are the lumbricals. So now what I have introduced here, synovial sheet. Where you can see the synovial sheet, you can see the synovial sheet here. Can you see this purple sleeve? So that is my flexor synovial sheet, and that is for each digit. This is flexor synovial sheet. And now what are these? These green bands. So these are basically the transversely going, the annular and flexor, flexor sheet, and that has been kept in its proper place. Where is the flexor synovial sheath of my fifth digit? Guys, I use a term here, radial bursa. What is that? Who is radial bursa? Let's go backwards. Look at the tendon of flexor pollicis longus. Can you see that? Tendon of flexor pollicis longus. Now see what happens at this place. A sleeve is coming, that is a separate sleeve. It's on radial side. We also call it radial bursa. Radial flexor synovial sheath. Same thing. We also call it radial bursa. And now look at it. My fifth digit, and then there's a gap for my digit 4, 3, 2. They all are in one place. So that should be my, if that was my radial bursa, so this should be my ulnar bursa. Can you see that? My pinky is directly connected. My fifth digit is directly connected to this bursa. Other synovial sheath, there's a gap in between. This concept has to be again clearer. What is radial bursa? What is ulnar bursa? They are the modification of flexor synovial sheaths. Going further, now you're looking at a nerve which is entering after passing through a tunnel. Who that nerve is? That's my median nerve. Excellent. Carpal tunnel syndrome. This is my flexor retinaculum. Yesterday, some of you was bringing up this question, volar carpal ligament. Volar carpal ligament is one small slip which is derived from this, but that's not flexor retinaculum. So that was not the right option. Somebody sent an appeal on that, so I said I will discuss this matter in the class. So you need to understand flexor retinaculum is a main entity and the volar carpal ligament is a small slip. It splits into a deep and a superficial slip, and one of the small slip which is derived from here, that is called the volar carpal ligament, and they are together making ganon. Wait, I don't want to go in those details because I don't think we need to go in that much. So this is, you're looking at the flexor retinaculum, and we talk about that the median nerve and the tendons of flexor digitorum superficialis and profundus and flexor pollicis longus, they all pass through this carpal tunnel. And you can see it. Now look at the ulnar artery. And look what happens to the median nerve. It gives a branch which is coming backward. Anything which is coming backward is called recurrent. You remember Dr. Sadia was talking about recurrent branches when she was doing the anastomosis around the elbow. She used this term recurrent. Recurrent means I came out of my home, I sat down in my car, and then I move a little bit. Oh, I forgot my mobile. I forgot my memory stick. I have to deliver a lecture. Then what I will do? I'll go back. So I'm recurrenting my way. My pathway is recurrent. So this branch is coming backwards, reverse pattern. So you can see that it's making a loop. So this is a recurrent branch, and that's the only motor component which is left in my median nerve. The rest of the median nerve is sensory now. After giving this recurrent branch of the median nerve, which is only motor component present in my median nerve. Rest of the median nerve is sensory, is cutaneous, has to supply the skin. So now look at it. It gives a digital branch. I told you this is not a motor branch. It's not supplying any muscle. It's only supplying the skin, the sensation. So it is going onto the second digit on radial side, on ulnar side, on radial side, on ulnar side of my third digit. First one I cannot show you the both in this view. And then the fourth digit on radial side. But not on radial side, not on ulnar side. So I can say very simply the sensory supply for my digit 1, 2, 3, and half of the fourth is dependent on the median nerve. But digit 5 and half of the digit 4, their sensory supply will be from ulnar. So on the palmar side, 3.5 digits are getting their sensory supply from the cutaneous branches of the median nerve. And digit 4, half of digit 4 and full of digit 5, their sensations are due to the ulnar nerve, due to its cutaneous or sensory branches. This concept has to be clear. So now you're looking at the digital nerves, and you have seen that median nerve lateral 3.5 digits are controlled by my median nerve. And what control? The sensations. It's not the motor activity. Motor branch is the only one which is recurrent, and you have been shown. So this one is my motor branch only. The remaining, which are going to the digits, they are just for general sensation. Now, my ulnar nerve from its superficial branch. You can see it's going, giving a digital branch for my fifth digit on the ulnar side, on the radial side, and then a branch for the ulnar side of my fourth digit. So my ulnar nerve is responsible on the palmar view for digit 5 completely and 4 half of it. So this is 1.5 is supplied by these nerves. Are we good? So these are the digital nerves. 1.5. Now this, I can have also another branch which is coming from median nerve before it enters my carpal tunnel, and that is called palmar cutaneous branch. So now I can identify if somebody present to me carpal tunnel, if I'm diagnosing somebody as a carpal tunnel syndrome, if that person has, because if this nerve has a problem in the carpal tunnel, then only the distribution, the sensation will be gone from my 3.5 digits and movements of my thenar eminence muscles. But the sensations at my palmar surface, skin of my palmar surface will be there because the median nerve was fine before entering the canal. So I can differentiate the injury to the median nerve is occurring in the forearm, in the arm, or this injury is occurring in the carpal tunnel. So if palmar cutaneous branch is working, it means median nerve was fine before entering. And if that is also gone, then I can simply say just by touching on the palmar surface, skin of the palmar surface, I can say no, median nerve was, it's not carpal tunnel syndrome. It's something different. So we can differentiate. So now, thenar eminence muscles. Guys, only you need to know the names and their actions and their nerve supply. Lucky you, you're not supposed to identify these muscles on cadavers. Only you should be saying this is thenar eminence muscle. And what are the name? What are those muscles which are present in this group? You need to know this much. You need not to know further detailing. So this muscle which you're looking at, that is my opponent's pollicis. So this is responsible for this opponent's movement. And then on top of it, a muscle which has been cut, that is my abductor pollicis brevis. I have an abductor pollicis longus. You know it from where it was coming. So abductor pollicis brevis. And then this is the last muscle, which is my flexor pollicis brevis. So these three muscles are the muscles of my thenar eminence. I should be knowing, I'm expected to know there is a thenar eminence connected to my first digit. And this heave of muscles have three muscles there. They are opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. All of them, they are supplied by median nerve. And the name says opponens brings opposition, abductor brings abduction of the thumb, not of the digits. And flexor pollicis brevis is the flexion of my thumb. So in the beginning, we talk about movements at the thumb. So these are responsible for that. So let's see this. This is the recurrent branch of the median nerve, and you can see it's supplying all these muscles. So now hypothenar. Let's bring hypothenar. First, same names, only you change half of it. Opponents, we'll not call it now policies, we'll call it appellants digiti minimi. Who this should be? Abductor digiti minimi. And this one will be flexor digiti minimi. Because we don't have any longus, so we don't use brevis here. So the names are same. Opponents, abductor, flexor. Pollicis or digiti minimi. 3 here, 3 there. And the nerve of my hypothenar eminence muscle is, you can see that ulnar nerve from the deep branch. It's supplying these muscles. Are we good? Now we are looking at what is happening. Something new has happened. My ulnar artery, after giving some branches there, it makes an arch with the one of the terminal branch of my radial artery. So the primarily my superficial palmar arch is derived from ulnar artery. It may connect with the radial, it may not connect with radial. It's conditional. Some people have it, some people don't have it. When you'll do dissection or when you'll come to the cadavers, you may not find this communicating branch. So the superficial palmar arch is primarily derived from ulnar artery. And then this deep palmar arch and superficial palmar arch, they are interconnected. And now we can have, guys, there are so many small names. I don't want you to go into this palmar and this and that. Simply remember, from the superficial palmar arch, we have digital branches and their job is to control all my digits. You can see that on both the sides. Are we good so far? So primarily remember, the superficial palmar arch gives digital arteries. That's it. No need to go into this common palmar and then palmar metacarpal and all that. No, it's too much for you. Simply remember, superficial palmar arch gives digital branches and that supplies blood to all my digits. And for the arteries, there is no superficial deep. They are controlling, they are giving nutrition to the digits, 3.5. You saw that 1.5 was coming from the deep arch. Now, who's that? This is my palmar aponeurosis. This is a thick condensation of the deep fascia, and this is being controlled by palmaris longus muscle. Palmaris longus muscle is attached to that, and palmaris longus only stretches this. So palmaris longus has to do very little role. I don't see any role, rather. Let me say frankly, has to do nothing with the flexion. Maybe stretching of this palmar aponeurosis. And there you are looking at the palmaris longus tendon, which continues here. So far, so we have talked about the arteries, we have talked about the nerves, and we talked about the muscles. Starting from, and these all muscles are intrinsic muscles. Who are intrinsic muscles? The palmar and dorsal interossei, the lumbricals, then the thenar eminence muscles and hypothenar eminence muscle, plus adductor pollicis muscle. Adductor pollicis muscle, we don't include him as a thenar or hypothenar. In some books, you may come up with, Doctor, I found one thing more, that is palmaris brevis. Don't get excited. It's there, but let's not talk about it. So let me give you a quick recap. All these muscles, hypothenar, palmar dorsal interossei, adductor pollicis, their nerve supply is from ulnar nerve. Who is not supplied by ulnar nerve? Thenar eminence muscle. Who are thenar eminence muscle? Opponens pollicis, abductor pollicis brevis, flexor pollicis brevis. They are supplied by median nerve. Then what else is supplied by median nerve? The lumbricals of digit 2 and 3. You remember, we talk about the flexor digitorum profundus 2 and 3. Their nerve supply was median nerve. And digit 4 and 5, their nerve supply is from ulnar nerve. So now these lumbricals, they are coming from this tendon, so they share their nerve supply. This is little bit overriding in your mind, but with the time when you'll read it more carefully, you'll be learning it. So primarily what I see, the chief motor nerve of my hand, of my intrinsic muscle, is ulnar nerve, because it controls so many things. All the interossei, half of the lumbricals, hypothenar eminence muscle, and adductor pollicis, all of them are innervated by ulnar nerve. So now you're looking at this palm cutaneous branch, which is responsible to supply the skin of my palm. So if I touch it here, I can tell the median nerve was fine before entering or not fine before entering. A simple touch can gives you so many. So you save hundreds of the tests. Now let's take the things out. Here you go. Everything is covered by skin. Everything is inside. So we have learned so many things. So I think let's break for 5 minutes, because it's too much cognitive load which you have been bombarded at. But unfortunately, this is what medicine is all about. I can hear. Do you mind turning on the light? Yeah. I'm listening. Let me wet my throat. Nowadays, after talking too long, throat goes dry, and then I'm getting something, bad throat and all that. Yesterday night I was talking around two and a half hour, because 30 minutes I was explaining to the peer tutors, and then I was back and forth with you in the review session. And then when I went home, I sat down with my wrist joint presentation and the Coley's fracture presentation, and once I'm done, it was almost 2 o'clock. And then I have to reach for this lecture, and this lecture I need to have energy, which I don't have at the moment. But anyway, I can survive, because I'm trained to work in all circumstances. Okay, so what is your question? Yeah, you can do that. I cannot hear you. You're wearing mask. So say it loud. They are all under the skin. They're not deep. This is thenar. You can see in your hand. Look in your hand. This is thenar, and this is hypothenar. Thenar, this eminence is thenar eminence. This is hypothenar eminence. I know this lecture is heavy. It has a lot of content. Can I share with you? Each slide has more than 100 animations. If I click that mode, you can see how many animations on one single picture. If you have to remove your skin, then you can see it. No, you cannot. You can imagine. You can imagine. You want to see? I'll give you a knife. Cut it. See. What else?
Now there is similar like this in the flexor side.
This is extensor side. Don't say flexor side. This is flexor side. This is palmar side. I have to start at 40. I have 2 more minutes to go. I cannot hear you. Yes. Okay, for tomorrow night. Tomorrow night I'll be reviewing with the female peers. So try to come early, because I have to start at 7, and I'll be doing the second phase of my review. That will be based on your interest. What do you want me to speak? If you don't write me, my life will be easy. I need not to spend 2 hours. It's up to you. You want me to do something? Send me tonight till
8 p.m. because I need time to prepare to complete your wish list. I don't want to come here and opening my book and scrolling randomly. No, I prefer if you are doing something, try to do in an organized way. Otherwise, say, sorry, I cannot do it, rather than doing half heartedly. If you are doing something, do with your heart. Or say it, bluntly refuse. I don't want, I cannot do it. Thank you. Talk some other time. So, if you want me to talk something today, send me by max by 8. So, I'll be ready tomorrow night from 7 to 9. I was, astonished. I saw the number of people who are listening to me directly. It was not a big number. Okay with me. But when I was just looking back, what Jabbar was showing yesterday, how many students were below and how many students were below, exactly it was reflecting the same. You understand what I'm saying? So if you have a hunger of learning, you'll be sitting there because whatsoever we are doing, if you are connected with me in my presentations, that is way better and way different because remotely, and once you're listening to the recording, you're not active. You have a feeling, and you know this feeling, oh, this lecture will be recorded, I can hear it at my leisure time. Yes, you can. But if you have real interaction, if you really looking in at that time when it is coming, then you have a deeper learning. But once you're learning, once you're listening it afterwards, then I don't see it in a big way. Anyway, people have their own priorities, people have their own focuses. So I think we should start. Yeah. Sorry. I think we can serve. Oh no, this picture is not good. So because those who are viewing on Zoom, they have a nice image, but those who are here, I don't want them to suffer because this light has to be like that. So guys, we have talked about, let me summarize quickly. We started from the bones, we talk about carpal, metacarpal and the phalanges. Then we talk about there are different ligaments. Then we talk about the tendons which are coming down. Then we talk about there are muscles, and these muscles we divided them into, primarily we talked about the intrinsic muscles of the hand. In the category of the intrinsic muscles, we talk about the intraosseous on both the dorsal intraossei and the palmar intraossei. We talk about the concept of the DAB, dorsal intraossei are for abduction and palmar intraossei are for the adduction. And then we talk about the lumbricals. Lumbricals also doing some special job. We'll be talking, not today, not this lecture, but later part we need to know that. And then after talking about those, then we started talking about the adductor pollicis muscle, which is not falling under the category of my thenar or hypothenar eminence muscles. So then after adductor pollicis muscle, we talked about 3 and 3 muscles, one for the thenar eminence, another for the hypothenar eminence, and these muscles were opponens pollicis brevis, flexor pollicis brevis, abductor pollicis brevis, and for the hypothenar, we talk about opponens digiti minimi, flexor digiti minimi, abductor digiti minimi. After saying that, we talk about the radial bursa, the ulnar bursa. Then I started talking about the radial artery. It runs in the as a content of my anatomical snuff box. It pierces first dorsal intraossei. It enters the palmar surface of my hand. It pierces the one head of the adductor pollicis muscle. It arches over. Before arching, it supplies my first digit and half of my second digit, and then it makes an arch which is deeper in location, and it is connecting with the ulnar artery, and we call it transverse or deep palmar arch. Then we talk about superficial palmar arch, and this superficial palmar arch was derived from the ulnar artery, and this ulnar artery, it may not meet with the counterpart, the radial artery, but this radial and this superficial and deep arches, they are interconnected through various communicating branches, and ultimate thing is they are giving, we derived the digital branches which were coming from my superficial arch. And then after talking about that, Then I talked about the distribution of the ulnar nerve and median nerve in the hand. These are really important concepts, and you are expected to be good. Let me tell you, when you see the exams, most of the final exams are loaded with questions which are connected to your hand. So don't cry at that time. So I'm telling you, you need to be very good with these distributions which are coming. So median nerve, it passes through carpal tunnel, enters the palm, there it gives a recurrent branch, and then it remains sensory. It controls the skin of my 3.5 digits, first, second, third, and half of the fourth. And ulnar nerve, primarily it supplies all the hypothenar, all the dorsal intraossei, and two of the lumbricals. And then it gives sensory supply to fifth digit and half of my fourth digit. So that is the fate of my nerves in the hand. We talk about arteries in the hand. We talk about the muscles in the hand, we talk about the radial and ulnar bursas, and now let's talk about, still the story is not complete yet, and a lot is there. And now we are looking at the skin which is covering my palmar surface of my hand. So now what we can see, finally, let's color it, make it a little bit complicated. So you can see the pattern of supply, the sensory supply of my palmar view of my hand, 3.5, and that is the median nerve. And 1.5, ulnar nerve. Excellent. And this part is radial. I'm talking sensations. Now, on the dorsum of the hand, ulnar, radial, and this much median. You need to be good with this because in your clinics, you'll be asked to test this, this, and that. And this is mandatory. And now, how I determine. If somebody tells you, you are allowed for one touch, you will not ask the patient to move anything. Can you determine the status of some nerve? Yes, you can. If I pinch at my pulp space or at the nail bed on my index finger, so I'm testing what? Median nerve is fine. Because if sensation is there, okay, sensation is there. So there are fair enough chances that motor will be there. This is for ulnar nerve test. And this is for radial nerve test. Just touching this spot, in my hand, median is right. In my hand, ulnar is right. In my hand, radial is right. We need to be good with that. Okay, I put it here on purpose. We had a long journey. We need to take a deep breath. But a silence is always reconnected. So, we talk about this concept. I don't think we need to go back to this slide. Only this slide is showing you the organization of superficial and deep arch. So let's go fast. But remember one thing. At the first web space, this line corresponds to what? Superficial palmar arch. And deep palmar arch at the base of the thumb. Sometimes the vignettes, before an MC, vignette is what? The stem of an MCQ. They will just say, someone has a cut at the base of the thumb, on the palmar surface of the hand. Or cut is corresponding to the first web space. Means what? We are talking about superficial or deep. So these are the key words. You should be connected to them. If you don't, you will miss that one question. One item will be missed. Okay, let's go. Yes, this will explain you. Now I'm not talking about flexor or dorsal. Now I'm talking about blood supply. This is an artery, a cut section. Who's that? Deep palmar arch. Who this should be? Superficial palmar arch? Who this should be? Dorsal. Perfect. dorsal carpal arch. We don't say palmar because it's not palm. On the carpal bones. So we call it dorsal carpal arch. Now you can see that my deep is supplying. So this is an example of first digit maybe. This is my palmar metacarpal artery, and now from the dorsal arch. See, superficial arch is connected with this one and is connected, it passes through the space between the digits, it's going on the other side. So they all are interconnected. Getting it? This is really important. You need to understand. That's why when you have a cut in your hand, you bleed profusely because blood is being poured from different sources, from different angles. Yes?
The superficial palmar arch is injured. It also injures the dorsal carpal.
No, it's not injuring that arch. It will get blood from the other arch. So they are interconnected. So, like what Dr. Sadia was trying to explain to you, anastomosis around scapula, anastomosis around elbow. Basically, she was trying to tell you the collaterals. Collaterals, you go on road, you have to, let's say there is an VIP movement. Announcement comes, today, Horace will be closed. So how you reach to uni? You use some detours, tahwilat. So these are the collaterals. So we have collateral channels. If the main is blocked, the collaterals can help. It will not be great. You know, when we use collaterals, what happens? Every small street become, you know, all the traffic will be disturbed. People are going in random direction and nobody knows where you have entered, what is happening. It's a chaos. You will be late from your school, from your office and every appointment. So, but there is a disturbance. But there is a way out if there is a traffic jam. Okay, so we can see that these are well interconnected and they are giving branches to all these joints. So these are called articular branches, which are responsible to supply the respective joints which are coming on their way. Now, we are looking at different movements of the hand. Now you have to tell me which one is power and which one is precise. What about number A? Yeah, hammer one. Power. And what about number two? Precise. Excellent. You're holding a small ball. And what about number three? Number C. So it's precision and power. You are holding a ball with precision, but then you're throwing with a force. When you're pitching this ball, you are adding a swing to that. So when the pitcher pitches his ball, it will go to the striker, and striker can see the ball is coming in, but all of a sudden it swings, it drifts in different direction. And then you use your striker to hit this ball. Then you can make a home run or whatnot. So this is power and precision. And what about option D? So these are the different modifications of precision. Holding a small object, holding a needle, holding a pen, all of them are different examples of precision. And what about this J? Where you are seeing somebody is holding a bag, a portfolio bag. What is that? Hook grip. What is that? Now tell me, what is A? Precision or power? Guys, here you have power and here you have precision. Can you see that? So you are using power and precision both. Power, precision. You want to be specifically at one small screw head. Now, image number B. What do you have here? Power is not. Precision, you are fixing, you are adjusting, and power with your digits. And now, image C. Only power? Power and precision, because you are supposed to be removing some nail or something with this clipper. Are we good? Now what is that? No, it's not median nerve. It's ductis contracture. That's something else. So don't bring me median nerve. Median claw is something like that, but this is different. So this condition is called Duptarian's contracture, and certain diseases patient presents with these kind of things. So not every claw is a nerve injury. That's why I put this image, and this is the description that what has happened. What is that? You might, if you connect to this image, now go back. Think of your surrounding. Have you seen someone, your granny in your home, your jad in your home, your grandmother, grandfather, or someone, their hands go like that? Do you connect to that? Yes. So this is rheumatoid arthritis. Rheumatoid arthritis is a disease of small joints. And if you don't take care of it in the beginning, you'll go for these deformities. So it is always suggested and it is always recommended, if you see somebody getting this type of hand, don't wait till you find all these deformities. Then correction is very difficult. You need to do multiple surgeries and you may not get the right answer. So prevention is better than cure. If somebody is affected, you should be intervening at the early time. Those who are affected with this rheumatoid arthritis, the best sign, in the morning when they woke up, they have pain in stiffness in their neck, their movements, their day begins with a pain. And most of the time, unfortunately, these are the females. And osteoarthritis, the pain which comes on after exertion. My weight goes more. I walk more. I stand more. I can see my knee getting swollen. I can have swelling in my hip, swelling this and that. So those are osteoarthritis. And there we have a disease which is coming step by step. It's not like you have bilateral in every joint, but in this rheumatoid arthritis, all the small joints are affected in one go. So we need to differentiate. This is just for your organizational thing, that you'll see people within your surroundings and they have fingers like that. Now I'm sure if you see somebody the fingers like that, it should be clicking to your mind, because your mind knows. Then you can see it. Otherwise, oh, I don't know what happened to her fingers. She was fine. My mom was saying she was fine 10 years back, but now she has maybe aging does it. No, it's not aging. It's a disease called rheumatoid arthritis. It has so many. Word arthritis means it has to do with the joints, and we need to be good at it. But remember, when somebody reaches to this level, now reversal is not that easy. The journey is difficult. Okay, guys, so this is the rheumatoid arthritis and its explanation. I think we are done. Alhamdulillah. Can you open the lights? I should record here. The recording should be stop share.
Doctor, do you know what
It's
Professor did?
hmm? I will tell you. I will call him again because he told me what he did. So why is recording? No, I don't need recording. Yes, I should. Where are those three dots?
Controls. I think he stopped recording.
Yeah,
Yeah.
so it should be stopped, paused.
You